When a patient presents with atrial fibrillation or AFib, that is really an abnormality of the electrical conduction of the top chamber of the heart, that it beats in an abnormal, usually fast manner, that's not synchronous or connected to the bottom chamber, that creates problems with fatigue and potential risk of stroke. It's actually the number one risk of stroke. And so there are many treatments that are available to not only manage atrial fibrillation, but potentially even cure atrial fibrillation. Here at the WVU Heart Vascular Institute, we have a comprehensive atrial fibrillation center and a unique team of cardiologists and specifically electrophysiologists, who are cardiologists of the electrical conduction of the heart, that have a multitude of both medical as well as catheter-based therapies to treat atrial fibrillation and manage atrial fibrillation, and surgeons that extend that one step further to the surgical therapy of atrial fibrillation, which involves ablation or putting in special lines inside the heart or outside the heart to attempt to stop atrial fibrillation and hopefully cure it forever. And the ultimate in those procedures is called the Cox-Maze procedure. Essentially, we create a maze so the conduction gets to the right spot properly without being erratic. Particularly over the last 5 years, we have participated in extensive work on robotic-assisted Cox-Maze procedure. And that is an operation for patients that have either exhausted existing therapies or failed previous therapies, medical or catheter-based therapies, or patients that have more than just atrial fibrillation. And the real special thing about the technique of robotic-assisted Cox-Maze procedure is that we can see the tissue lines beautifully and very precisely. And our position is that by doing it robotically, a surgeon now has 5 hands on the patient instead of 2. Of course, in the front, it's the surgeon with 2 hands. Robotically, we have a tableside surgeon and we have a robotic surgeon, and the robot has 3 arms. So with that, we're able to very clearly see every line of the patient's heart to make sure that those lesions get done precisely. And it is that precision that can be facilitated by this technique of robotic-assisted Cox-Maze procedures that provides that extra enhancement to assure the lesions are done well and thoroughly. On the day of surgery, they come in, they meet our anesthesia colleagues, they get a special injection in their back and a catheter in their arm. The injection in the back is to cause some freezing for pain control. And then once under anesthesia, it's a small incision on the side. And through that small incision, we go through the ribs. We don't break any bones or anything like that. And then expose the heart, put the patient on the heart-lung machine, stop the heart, go inside the heart, and then place very special lines that really is the description of the Cox-Maze procedure. It starts into the left atrium, and the first step is a epicardial or on the surface ablation using the freezing wand. The second is ablation lines on the inside of the left atrium, what's called the floor lesion, the roof lesion, and the mitral line. Those are all usually for 3 minutes. Then we go to the right side of the heart, the right atrium, and do lesions to complete towards the tricuspid valve, a lesion along what's called the superior vena cava, or the upper vein of the heart, the right atrial appendage, and the inferior vena cava, which is in the lower vein of the heart. Once that is done, the ablation portion is complete, and then And most importantly, we completely obliterate the left atrial appendage. Now that is done with a very precise technique that we've worked on here and proven time and time again, that it completely obliterates the left atrial appendage in a very safe and homogeneous, smooth way. Why is that very important? Well, many of these patients are often on oral anticoagulants because of the risk of stroke in atrial fibrillation. Well, in our experience through this technique, we've been able to successfully send people home without anticoagulation, oftentimes for the first time in many months or years. And we have shown longitudinally or through follow-up that the risk of stroke is essentially similar to the normal population. And so it's a way to not only cure the atrial fibrillation, but also reduce the burden and reliance on certain medications. Patients are usually in the hospital around anywhere from 3 days to 5 days. Usually after the Maze procedure, we want to make sure their rhythm is nice and regular and fine before we send them home, and that usually takes between 4 to 5 days. And then once they're at home, they can resume their normal activity, just no heavy lifting or driving for about 3 weeks, and then people usually return essentially to near normal thereafter, and restore their quality of life and get back to doing what they want to do. Once people are discharged, they become on a pathway towards cure. Now, it takes several months for the lesions that we put inside the heart to form proper scar, which is then creates this proper interruption of the electrical signals and restoration of regular rhythm on an ongoing basis. We support the coverage of while the heart is healing with an oral drug, commonly called amiodarone or sotalol, to prevent any type of blips from occurring. After 3 months, we stop this medication and then watch patients very carefully. And we follow them in our own office personally, several times in the first year, twice a year between the first and second year, and then once a year thereafter, to really assure that long-term their success rate is established. And we usually don't use the cure word until after about a year. So the risks of the robotic Cox-Maze procedure are similar to any risks of any heart operation. Bleeding, infection, stroke, heart dysfunction, kidney problems, and lung problems. The same for anyone going for any form of heart surgery, but the risks are tailored to what people come to. So there's not any undue extra risks associated with it. In fact, we do know from national data that when we add a Maze procedure to patients that have other valvular problems, we can actually decrease their net risks of complications such as stroke or other issues. And that's a really positive thing that only recently has been shown through large data that it justifies not only doing it and helping them long term, but even in the short term.